Okay, my name is Taylor Pumphrey. I'm a senior athletic training major here at Emory-Henry. The title of my project is Hip Labral Tears in 2 Female Division III Volleyball Players, and this is a case series. Just a quick introduction to my project. Acetabular hip labral tears are becoming an increasing injury in the athletic population. Just in the past couple of years, it's kind of gotten a lot bigger. It's often associated with the older population and like degenerative injuries. Often these patients will complain of anterior hip pain, so a lot of times it gets mistaken for like inflammation of the joint, a fracture if there's a direct mechanism, infections, arthritis in early stages. I had 2 subjects. The first subject was a 20-year-old female athlete who tore her acetabular hip labral tear in her left hip, and it was on the anterior portion. She played the position of right side hitter, and she underwent a hip arthroscopic repair procedure, and she went through a rehabilitation program. Athlete 2 is the one I really had a lot of work with. I worked with her a lot. She had an anterior acetabular hip labral tear in her right hip. She plays the positions of, she's a defensive specialist, and she's also a libero. She underwent a hip arthroscopic repair procedure this past year, and I created a rehabilitation program based on a protocol given to her by her doctor who completed the procedure. Because both of these athletes both play Division III volleyball, they're both female, and they didn't have a direct mechanism for injury, this kind of inspired my clinical question, which was, are there specific risk factors that put female volleyball athletes at a higher risk for sustaining this injury? Just an overview of the literature that's out there. The main soft tissue that I'm going to talk about is the acetabular labrum. This is a fiber cartilaginous structure that outlines the acetabular socket. It meets the transverse acetabular ligament at the inferior border of the socket. It's triangular in structure. It's thinner anterior and thicker posterior, which a lot of labral injuries occur anteriorly. It's made of type 1 collagen fibers mostly, and there's not a lot of vascularization that like innervates the labrum, so that's why a lot of physicians and a lot of research say that eventually if you sustain this injury, you're going to have surgery, because the blood flow is not going there and it's not going to heal on its own. Women versus men, especially like in pelvic structure and bony anatomy, women usually have a tilted pelvis and usually it's tilted forward. They usually have larger, broader, and shallower pelvis, and this is for childbearing. The bone thickness, they usually have a lighter and thinner pelvis, and their acetabula is usually smaller. Men, on the other hand, are basically completely opposite. They have thicker bones, it's heavier, and usually they have more predominant markings. Mechanisms of injury. In the literature, they talk about 4 main mechanisms. The first mechanism is traumatic, so this comes from your big traumas. So if you have a traumatic tear, you're going to know what happened. So hip fracture, subluxation, dislocation, those are your big ones. The next one is degeneration. Like I said earlier, this injury is seen more in the older population. So once you're older, your hips start to break down, and which could cause this injury. The third one is idiopathic, which is where a lot of my research focused around. This is when there is a mechanism of injury, but there's not any degeneration in the hip. So this can come from hypermobility, twisting motions, like tiny microtraumas. So just constantly falling on your greater trochanter can actually cause labral tears. And then the last one is congenital, which is just when you have an abnormality at birth. So it's just kind of there. Risk factors. There's not a lot of research looking at risk factors for this injury. They have found that coxa-valga, coxa vera, and then femoral anteversion and retroversion can potentially be risk factors, but other than that, there's not a lot out there. This is the picture of the acetabular labrum. You can kind of see the triangle structure it kind of comes up and it meets the transverse ligament at the bottom. Okay, so methods. My project had two main, parts to it. The first part was a rehabilitation program for athlete number 2. I created a rehabilitation program, as I talked about earlier, based on the 3 phases of the healing process. I also added a 4th stage, which focuses on return to play, that kind of overlaps into the 3rd phase. So just really quickly, the first phase, I started about 3 weeks post-operative. She was still in a brace. We had it, she was limited to 90 degrees of flexion. The goals for this phase were to decrease swelling, decrease pain, and then incorporate early and appropriate range of motion. A couple exercises, just examples that I incorporated, would be stretching. We focused on the piriformis and hip flexor and hamstring. We also did joint mobs. We did anterior and posterior, and then we did joint distraction. We did involved knee to chest, and then 1/3 knee bends, which are basically just body squats, but you just limit how far they can dip down. I have pictures later of a few of these. The second phase, we started around week 5, and the goals for this were to increase the strength, increase range of motion, and then try to increase neuromuscular control. For this one, examples would be the elliptical. We incorporated more intense swim workouts to try and get her cardio up. We incorporated closed chain exercises such as leg press, body squats. We did single leg stance, a couple step up exercises, and bird dogs. By the end of this, the measurements that I took at the beginning, which were girth, range of motion, and strength, I think I said that. By the end of this phase, most of that had returned to normal. Her girth measurements and range of motion returned to normal. The third phase, we started around week 7, and we just wanted to continue with strength, range of motion, and neuromuscular control. This one kind of overlapped with week 4 because I did incorporate some sport-specific movements and stuff. So we started with jogging and things like that. But the 3rd week, mostly, it consisted of Basu squats, Pilates skaters. We did single leg stance on the AirX with the ball throwing. And then we incorporated gentle plyometrics, which consisted of like gentle hopping and like lateral steps on the step and things like that. So like I said, the 4th stage overlapped, but towards the end of, or the beginning of 4th stage, we started to do lane slides, a lot of lateral movements and zigzags, just to get her back to feeling comfortable moving around and using that hip. The second part is the measurements. I measured strength, range of motion, femoral angle, Q angle, and pelvic obliquity of both athletes. Like I said earlier, femoral angle had already been identified in the literature as a risk factor, so I wanted to look at that and just see if the athletes that I had participated in my study had that as well. Basically, I chose these because all of these can lead to a change in the position of the femur and the socket. So it can change that angle, which can put increased pressures on different parts of the acetabulum, putting it at risk. Here's some exercises. Little block face. The top one is involved knee to chest, and we progress that by putting weight on it and the squat. Bird dogs. There's the 1/3 knee bends. As she got stronger, she was allowed to go deeper into the squat. There's single leg bridging, and then there's the gentle plyometrics with the lateral step. We timed it, and she had to go back. Results. These are the measurements from athlete 1. This is the 20-year-old female. She had an anterior tear in her left hip. Most of the results were normal when compared to like norms of evidence-based practice. The 2 that really stood out were femoral angle and then range of motion. They were limited in range of motion of hip external rotation. Normal measurements for femoral angle were about 15. If you had 15, you were indicated as having anteversion. So as you can see, they're way over 15. So she had extreme femoral anteversion bilaterally. And normal range of motion measurements are about 45 degrees, and she was extremely limited there. If you look at athlete 2, same thing. The only difference is that for femoral anteversion, she has more extreme anteversion in the hip she actually injured. And then external rotation, she's extremely limited as well. So my conclusion, because there's not a lot of research supporting these findings as risk factors, I can't conclude that they are risk factors for it. However, my findings do support the literature and the research that is being done. Some of my limitations, I did my project last year, my rehab project, so there were a lot of things that I was thinking of this year that I really wish I would have incorporated. 2 of these things, I think it would be really cool if we could have gotten x-rays and radiographs of their labrum and like just bony anatomy and compared them to see if there was any bony abnormalities or abnormalities in the labrum that could have caused their injuries. My other one was compliance towards the end of the program. Just because exams were coming and summer was coming, it was a lot harder for her to get into the ATR, so we had to do a lot of take-home workouts, which while that's better than nothing, I still think that if we would have worked out in the ATR with the different resources we had there, her program might have been changed a little bit. Delimitations, like I mentioned a little bit, we only did a 6-week program because of summer, and that last week we probably could have done workouts, but with exams and stuff, it was just hard to find a time to meet. For future research, I think that continuing to research these factors would be good, because if we can identify them, then there's possibility of preventing these injuries in at-risk athletes in the future. So once we identify them, just maybe even possible for prevention programs. So that is it. Any questions?